guess probably the last class for this group of examinees, and I wish all of you best wishes, and I'm sure all of you are going to do well. Don't worry. You must remain cool while you are answering the questions today, but I'm sure this is in preparation for your exam on the 7th, but I'm sure this is just to sort of tickle your brain to start thinking in terms of asking. And so this is to just give you a small sort of a step in that direction. And I am very glad to have two volunteers actually for this. You can say volunteers because I wanted two people who have some kind of an experience in having appeared in these kind of exams, and the two people who struck my name was Ajay and Sagar, and both of them have appeared in these exams in internal medicine board in US and the nephrology boards in the US again, and I thought that they are the right people who are likely to do this. So I must have the pleasure of introducing both of them. And although Ajay, you may have seen in the previous classes as well, but we are soon going to get Sagar into our regular roster, and I've asked him, and he's very glad to do that. Sagar is a graduate from Maulana Azad. Both of these boys today are from Delhi boys, you can say. So he graduated from Maulana Azad and then went to US and graduated from Beaumont University and in Michigan actually. And Michigan is where in Henry Ford Hospital, way back, long time back, I was there. So it feels very, very familiar. He did his residency in internal medicine there and then moved to St. Missouri. And that's wonderful Washington University School of Medicine, and there he did his nephrology and then transplant fellowship. This is one of the very highly rated nephrology centers. As such, Washington University is a top university and very highly acclaimed. So it's always very good to have people coming from that kind of university background and all that. So welcome, Sagar, to our group as such, and this will be your take. You will go first, and after that, Ajay, they know Ajay is again a graduate from All India Institute of Medical Sciences, then went to University of Indiana, Indianapolis, did his residency there, then did nephrology at the Beth Israel Hospital, and did transplant fellowship also at this. So these two people have had similar kind of education in two different parts of the world, but very good universities. All of them, everybody can feel very proud of it. And they're so glad to see both of them take today's class with you. They will give you some 10 questions each and then take you through the answers later on. I think you must answer the sheets which have been, which you should have downloaded and printed them. You should mark them and do your own conscious kind of assessment for your own performance as to what it is. This should make you think. You could go back. They are going to give you the answers at the end of it, but I would suggest that you should do reading in this kind of a fashion to appear in your exam on 7th. All the best, and it's all over to you, Sagar. Thank you for participating in this, and I will take off and let you guys handle it. Thank you very much, and all the best for the examinees. All the best. Thank you very much.
Thank you so much, Dr. Ker. It's my pleasure to be here and to be involved in such activities. Like Dr. Ker mentioned, our US pattern of examination, this had similar questions where you're looking at a clinical case scenario. You have to read the question stem, and then, that's followed by a question and 4 options. Most of the questions today we've kept kind of, like shortish, not many of them are not too long. One exam tip we used to one tool we used to use was always, you can read the question line first and then go back to the question stem, because sometimes the questions are very long and you may get lost in the process. So I'll try to go through the questions, and we'll have 2 minutes for each question to write down the answer. Take your sheets and you should jot down the answer, what you think is the correct answer, and then we'll come to the answer key and go over the explanations and the correct answers. Again, thank you, Dr. Ker, for having me here, and we'll start off with the first 10 questions. It doesn't share my screen for some reason.
It was working before. You want to try it again?
Yeah, I'm trying it again, sir. I think maybe the setting was changed because the steadfasting came up. My PowerPoint is rebooting for some reason. Sorry for the glitch.
Sagar, you can give it a try. If it's not working, then I'll try mine, and then we can try and come back.
Yep. Just give me 1 sec.
Sure.
Can you see the screen share now?
Not yet.
You want to go first, Ajay?
Sure. I'll try and go first then.
What's wrong?
Okay. And everyone, can you see my screen now?
Yes, sir.
Okay. So then I'll go first. So for everyone taking notes, we'll start with case 11. So on your sheet, you can start from 11 and go on to 20, and then we'll come back to Sagar's questions. So again, we'll give 1 or 2 minutes for the question. You'll have a couple of minutes kind of go over the kind of pick off the answer, and then we'll come back go over the answers. So case 11 is going to be a 60-year-old male with no past medical history and presented to his physician with some fatigue and weakness, and was found to have hypertension with a blood pressure of 160/100. A routine for testing found some trace urine protein, creatinine of 1.2 with a hemoglobin of 11, WBC of 6.4, and platelets of 180. The physician started him on amlodipine 10 milligrams daily. A few days later, he developed severe flank pain, and for the flank pain, he underwent a CT that showed a wedge-shaped renal infarct. And so he underwent a renal angiography with the image as here. And so the question is, what is the diagnosis for this person? Is it A, granulomatosis with meningitis, Wegener's; B, antiphospholipid syndrome; C, polyarteritis nodosa; D, aortoarteritis, Takayasu's; or E, lupus nephritis. So you'll have a minute or so to kind of think it over, look at the image, and then we'll go over to the next question. Okay, so I'll move on to the next question now. So this is case 12, a 65-year-old male with Wegener's granulomatosis, diagnosed 1 year ago and in remission with a baseline creatinine of 2.5, maintained currently on azathioprine. He presents with severe left big toe redness and pain and an inability to walk because of the pain. What would be the next step in management? Allopurinol with steroids, which is option A. Only allopurinol, which is option B. Buxostat plus colchicine, which is option C. Colchicine with steroids, option D. And option E is the buxostat with steroids. So we'll give another 30 seconds to a minute, and you can choose your answers. Okay, so now I'll go to the next question. This is case 13. So this is a 60-year-old stage 5 CKD and has been on dialysis for 2 years. He's been doing dialysis 3 per week. Over the last few 3-4 months, he's noticed a decrease in urine output and is now having symptoms of poor appetite and early morning vomiting. His KT by V is 0.9. Which of the following would make the biggest change in his KT by V? Increasing his time from 3 hours to 4 hours, changing his dialyzer from FX8, which has a urea clearance of 293 on the sheet, the product sheet, at a blood flow of 400 ml per minute, and FX60, which is a high flux, with a urea clearance of 303 ml per minute at a blood flow of 400. Again, this is on the product sheet. Option C is increasing the blood flow from 300 ml per minute to 400 ml per minute. Option D, increasing the dialysate flow from 500 ml per minute to 800 ml per minute. So take your time, and we'll give you a minute on this one. So we'll move to the next question, which is case 14. So this is a 40-year-old stage 5 CKD who's been on dialysis for 2 months. He's planned for an ABO incompatible transplant, B2O, with wife as his donor. He's received rituximab and is on tacrolimus and MMF as his routine for ABO incompatible. He initiates plasmapheresis for an anti-B titer of 1:256. During his second plasmapheresis, he first describes some headache and his blood pressure is 180 by 110. He's given some clonidine, and a little bit afterwards, he suddenly describes complete loss of vision. A few minutes later, becomes drowsy. Plasmapheresis is stopped. He's transferred to the ICU. An MRI is done, and the image is here. So what would be your next step in management? Option A is to stop his MMF. Option B is to stop his tacrolimus. Option C is to restart his plasmapheresis. Option D is to proceed for immediate dialysis. And option E is to plan a brain biopsy. So we'll go to the next case. This is case 15. A 55-year-old female with stage 5 kidney disease and has low-level donor-specific antibodies against A02 at 3000 and a negative CDC and a negative flow cross-match with Sun as a donor. So after discussion of the antibody risk, she undergoes transplant with 1 session of plasmapheresis and ATG, which is 4.5 milligram per kilogram. Post-transplant, the creatinine does well. Creatinine comes down to 0.7. 6 months later, she comes in for a routine follow-up, and the creatinine is now increased to 1.2. She is currently on tacrolimus 2 mg BD, MMF 720 BD, and Viaslone 5. There's a normal exam, normal ultrasound with Doppler, and her tacrolimus level is 8 nanogram per ml. Kidney biopsy is performed, and the biopsy is here. So what's the next step in your management? Are you going to do option A, plasmapheresis with steroids, ATG, and rituximab? Option B, plasmapheresis with steroids. Option C, steroids with ATG. Option D, stop MMF and decrease tacrolimus to a target of 4 to 6. And option E, increase steroids to a 1 mg per kg dose. I'll give you a few minutes on this one. Okay, so now we'll go to case 16. So case 16 is a 30-year-old male who is a runner. He notes some swelling in his legs, and the evaluation shows proteinuria, and he's referred to nephrology. He's normotensive with a blood pressure of 114 by 76, heart rate 60, with minimal edema. Urine shows 1 plus protein. A spot urine protein creatinine ratio is 3 grams per gram of creatinine. Serum albumin is 3 grams per deciliter, creatinine 0.9, and he undergoes a kidney biopsy, which is here. So what would be the next step in the management of this patient? A, giving him rituximab. B, steroids and cyclophosphamide. C, calcineurin inhibitor. D, mycophenolate mofetil. And E, telmisartan. Okay, we'll go to the next one, is 17. So this is a 65-year-old female with coronary artery disease with triple vessel disease with no previous intervention done. Has diabetes and hypertension, well-controlled blood pressure and amlodipine for 5 milligrams for many years. The last 4 to 5 months, the blood pressure has been now 170, 180s, over 90 to 100. And this is despite addition of telmisartan, carvedilol, chlorthalidone, and also increasing the amlodipine to 10 milligrams. Labs done show creatinine of 1, urea of 30, sodium 145, potassium 3.3, uric acid is 6, normal liver function and thyroid function. What would be the next step in management? So option A is to do a plasma renin as well as aldosterone ratio. And after stopping the interfering medicines, followed by a CT of the adrenals. Option B is to start spironolactone. Option C is to do a renal Doppler. Option D is to do serum and urine metanephrines and catecholamines. And option E is to start clonidine. And 10 more seconds, and then we'll go to the next question. Case 18, a 45-year-old female who's post-op from her lap polycystectomy and has nausea for the last 2 to 3 days. Have sudden change in mental status and has drowsiness. Lab sent show a serum sodium of 115. He's been on normal saline at 75 ml per hour for the last 2 days. Has minimal oral intake. What would be the next step in management? Option A, stop normal saline and give 3 gram salt tablets. Option B is to give 3% 100 ml stat. Option C is to increase the normal saline to 150 ml per hour. Option D is tolvaptan 15 mg stat. Option E is fluid restriction 1 liter per day. Now we'll go to case number 19. So this is a 55-year-old female with CKD stage 5 on 2 per week hemodialysis. Presents to the emergency with weakness and altered mentation. Blood pressure is 80/40, heart rate's 45, and the ECG is shown here. Which of these is most critical in her management? Giving insulin, option A, giving insulin and dextrose and repeat in 4 hours. Option B, sodium bicarbonate, repeat every 5 minutes. Option C, albuterol nebulization, repeat every 5 minutes. Option D, calcium gluconate, repeat every 5 minutes. And option E, furosemide. Give 10 more seconds. We'll go to the next one. Okay. So case 20 is a 50-year-old male who has been on dialysis for 6 years with hemodialysis, has multiple failed accesses and is currently on a femoral pacemaker. He's been anuric for 1 year and his weight is 50 kilograms. After multiple counseling sessions, he's agreed to switch to PD and has had his PD catheter placed 1 month ago. And he's also completed his PD training. He gets his test done yesterday, and his dialysate to plasma creatinine is 0.5 at 4 hours. And his dialysate to D0 glucose is 0.55 at 4 hours. What PD prescription would you advise for him? Option A is to give 2 dwells of 6 hours with 2.5%, 2.5 liters, 1 night dwell with icodextrin of 12 hours, 4 dwells of 4 hours with 2.5%, 2 liters, and 1 night dwell of 8 hours with icodextrin. This is option B. Option C is cycler with 2-liter exchanges of 2 hours each for a total of 10 liters and over 10 hours. And option D is 1 dwell with 2.5% 2 liter for 4 hours and a cycler of 5 liters over 8 hours. I'll give a minute on this one and then we'll take the answers. Sorry. So last 10 seconds and then we'll go to the answers. And please feel free to put in questions in the chat or unmute and ask questions in the middle of the answer session. Unfortunately, I don't think I can see the chat questions so far. Let me see if I can pull that up. Yes. So in case anyone has questions or things they want to put in the chat, they can do it that way. Or they can just unmute and ask questions as well. And so now we'll go to the answers. So hopefully everyone's been able to put a answer on 11 to 20. And we'll kind of go to the cases again. So case 11, someone with new onset hypertension with some trace proteinuria, with flank pain and a renal angiography and a renal infarct. And so for the key is to see the aneurysmal dilations, which we've put here, infarct of the kidney at the lower pole, and the classic aneurysmal dilation is what is a giveaway for polyarteritis nodosa. And so the answer for this is C, polyarteritis nodosa with the infarcts and the classic small microaneurysms. So that's case 11. Case 12 is a patient with Wegener's who's on as azathioprine and has a classic gout pain. And so the question options were to give uric acid lowering drugs with steroids or with colchicine. And then the option was one option where there is no uric acid lowering drug, which is option D. And that is the correct answer because you do not want to give allopurinol or febuxostat in the setting of azathioprine, as the azathioprine will accumulate and it will cause severe aplastic anemia and can even lead to death. In addition, if you are going to start someone on a uric acid lowering drug, you want to do it after the flare and usually under the cover of steroids or colchicine. As soon as you start someone with uric acid lowering drug, that can trigger a flare of gout as well. So you usually want to do it under some steroid, colchicine or NSAID cover. Okay. Any questions on question 11 or question 12? Please feel free to unmute and ask or put it in chat. My chat doesn't show up when I'm doing the question answers. Okay. So far, nothing. So I'll move on to question 13. So this is someone who is poor KT by V. And the question is, how can you make a change on the KT by V in dialysis? So we'll go over each of these options. The answer for those keeping score is answer A. And so the increase in clearances by each of these measures will kind of go. So option A, you increase time from 3 hours to 4 hours. So the increase is 1 hour, and it's 1 hour over 3 hours. That's an increase of 33%. So if you increase time from 3 hours to 4 hours, you'll get about a 30 to 33%. The clearance is not exactly going to be that because your urea has already decreased some, but it will be around 30 to 33% range. If you change the dialyzers, the increase, so we'll go back to the clearance. So you can look at the product insert. And for FX8, if you change the dialyzer from an FX8, so it goes from 293 ml per minute to 303 ml per minute. So that's an increase of 10 over an approximate of 300. So that 10 by 300 is 3%. That changing from an FX8 to FX60 only increase your clearance by 3%. You change your blood flow from 300 ml per minute to 400 ml per minute, and we keep the dialyzer at FX8. Again, you can look at the product insert, and what you'll find is for a blood flow of 300, usually depending on the dialyzer, we'll get somewhere around 250. And when you get to around 400, you'll get about 290 or 300. So you get an increase of about 40 to 50 when you increase the blood flow by 100 from 300 to 400. And beyond 400, you'll plateau and you won't get much further increase beyond that. So a 40 by 250 blood flow, 40 by 250 is a 16% increase. If you increase your blood flow from 300 to 400 ml per minute, you get an increase of about 16%. And option D was increasing the dialysate flow from 500 to 800. That's been shown to increase your clearance only by about 10%. So between the three options, increasing time by 1 hour will increase your clearance by 33%. Changing the dialyzer will be 3%. Changing your blood flow will be an increase of 16%. And changing your dialysate flow will be an increase of about 10%. Someone had a question. Let me see. 250 as the denominator. Okay, so we'll go back to the previous question. So the denominator is 250 because the blood flow at 300 has a urea clearance of 250. So if you look at the curves for any dialyzer, they're not 100% clearance because the equilibration in hemodialysis is not 100%. So in a dialyzer like FX8, at a blood flow of 300 ml per minute, you'll get urea clearances about 250. And so that's why when you increase the blood flow from 300 to 400, you're starting with 250, you get to 290. And so that's why the denominator is about 250. You can do 254. That'll be more accurate, but that's kind of, yeah. So next is case 14. So this is our ABO incompatible transplant who's on plasmapheresis and has headache with a blood pressure that has suddenly rocketed up and then has loss of vision. The MRI shows classic PRES, posterior reversible encephalopathy. And in terms of things to do, tacrolimus is the drug that is associated with PRES, especially in those who have renal failure or ESRD. Again, this is classic presentation with a sudden onset high blood pressure, some mental or vision changes that this person had. And so again, you would want to treatment-wise do good blood pressure control, remove any etiological agents like tacrolimus, and in this setting, you may even need to stop or hold his transplant till this resolves. Next is our case 15. So this is someone who had a low-level donor-specific antibody, undergoes transplant with ATG and plasmapheresis, and then has an increase in creatinine and biopsy is done. So the biopsy here shows diffuse infiltrate, below interstitial infiltrate as well. Tubulitis is there on the left. And on the right are these cells with intranuclear inclusions. I hope you can see my pointer. So there are these cells with intranuclear inclusions here. And so that is Bkv nephropathy with intranuclear inclusions. And the treatment would be a decrease in immunosuppression, which option is option D. One way you can differentiate Bkv from rejection would be either immunofluorescence, in which Bk would have SV40 staining, antibody rejection would have E4D staining. In terms of H&E or PAS, the only difference would be endothelialitis. If you see endothelialitis, so in case the inset has an has a vessel with endothelialitis, this is rejection, and that can't be Bkv. And then the treatment would be increasing immunosuppression versus here where it's decreasing immunosuppression. So option D, which is stopping MMF and decreasing tacrolimus, is the answer. Next is case 16, in which we have a runner with some swelling in his legs and proteinuria. But the key features are that his urine protein creatinine ratio is only 3 grams with a serum albumin of 3. And his biopsy is classic membranous with spikes and holes, especially on here. And so this is membranous, and the options are treatment of membranous, which is Ritux, steroid, cyclophosphamide, calcineurin, MMF not so much, and then telmisartan. So the question predominantly is about what do you do for someone who has low risk of progression, because that's what he classifies as, with serum albumin, which is 3, minimal edema, and a UPCR, which is not nephrotic. So for these patients, the teaching is to monitor them for 3 to 6 months with an ACE and an ARB, as a spontaneous complete remission can occur in them, to tune of 5 to 30% at 5 years. There's another question that popped up in the chat. Okay, so there's some question 15. So I hope Tim can unmute and ask his question as well. Tim, you can unmute and ask your question. Okay, so the question is, can rejection and Bkv coexist? Usually not. Theoretically, yes, but usually not. Because what will happen is, the first thing is either your immunosuppression is too high or your immunosuppression is too low. And so you'll either have a rejection or a Bkv. However, when you make changes, then you can get second one added on. So let's say you have someone who's had Bkv. As you lower your immunosuppression, you could get a rejection on top of the Bkv. So that is something that can happen. But as a first case, and as a first thing that happens to a person, you usually won't have Bkv and rejection together. So they'll start off with, let's say, Bkv, you lower immunosuppression, you lower it a little too much. Then later on, rejection can happen on that setting. Similarly, you could do it the other way around. You have a rejection, you hit them hard with immunosuppression, and then the rejection subsides and Bkv kicks in. Usually it will be one, and then the changes that you do may lead to the other. But as a first case or a first presentation, you won't have both. So now we'll go to question 17. We did the membranous. So we have a 65-year-old female with coronary artery disease, with triple vessel disease, diabetes, hypertension, is now presenting with resistant hypertension with a new onset, with failure with telmisartan, carvedilol, chlorthalidone. And so what I'm describing is someone who has hyperaldo. I'm giving you the potassium, which is low, the sodium, which is slightly high. The main question is, are you going to investigate someone for hyperaldo, or are you going to treat them with spironolactone directly? And the reason you would want to do the option as option B is that at 65, if you are going to investigate someone for hyperaldo, you would have to do multiple steps. One is the hormone testing, then would be the CT to identify location, or do adrenal vein sampling and then do surgery. The person is 65 with coronary artery disease with untreated triple vessel disease. So from a surgical standpoint, she is likely not going to be a candidate. For patients who are not candidates for adrenalectomy or adrenal vein sampling, it is better to just move forward with medical treatment. As it is for people with resistant hypertension, the fourth medicine that we should add, so after the three, is calcium channel blockers, ACE and ARBs, and thiazide. The fourth medicine that we should add for all patients with resistant hypertension is spironolactone. And so in this, the treatment would be spironolactone with normalization of potassium, blood pressure, and reversal of hyperaldosteronism as the goal. So, so someone's putting in that renal angio-aldo system could be up, and potassium can be low because of RAS stimulation. So yes, so potassium can be low from that as well. At present, the main question would be she has triple vessel disease. So if she has triple vessel disease, even if she has renal artery stenosis, it is unlikely to be fibromuscular dysplasia. It is likely going to be atherosclerotic renal artery stenosis, in which case also the treatment would not be to do any endovascular stenting or pasties. It would be to use medications, and she's already on an ARB, so the treatment would be to add spironolactone in that setting. So even if we assume that this is likely to be atherosclerotic renal artery stenosis, the treatment would still at present be predominantly spironolactone for treatment of resistant hypertension, in which aldosterone has a very spironolactone has a very good effect or efficacy.
Hello, good evening. Sir, if we can do a Doppler instead, and if the creatinines are rising, even at this age, there are only few indications remaining for intervention as of now. But if the creatinine is rising, as I think mentioned in the question, will this not be a reason to?
Question doesn't have anything about a rising creatinine. The creatinine is stable. This is resistant hypertension.
Resistant hypertension.
This is resistant hypertension with no other indication for a plasty or a renal artery intervention. So if this was someone who had multiple episodes of flash pulmonary edema, rising creatinine, there may be an indication to kind of intervene or assess and then consider intervention. But if this is, even if this is renal artery stenosis, which is possible, she has coronary artery disease, she could have atherosclerotic renal artery stenosis as well. But the treatment or intervention for that at present would not be indicated. And the treatment would be spironolactone, because resistant hypertension with or without hyperaldo, spironolactone would be the best choice or the first choice in that kind of a treatment. We could do a PRA and aldosterone ratio to document what the aldo is without stopping the telmisartan, because one option would be to stop the telmisartan and then do a renin aldo. But if you want to just get a sense of what the renin aldo is, we could consider doing a renin aldo and then start the spironolactone. That would not be an unreasonable way to do it. And as you can see in the answer 17B, I had that as an option. Somehow I forgot to change it in the question, that you can send a PRA aldo and then start the spironolactone. Somehow I didn't change it in the question when I was making the answer. So that is fine. But in my mind, I wouldn't wait for the PRA aldo. This is resistant hypertension. Even if I find hyperaldosteronism, I wouldn't intervene on it because she's not a candidate for any adrenal vein sampling or surgery. If she were a candidate for surgery or adrenal vein sampling, that would be a different discussion.
Sir, is 65-year-old would be a age for hyperaldo in the sense it will
Anyone
not
can anyone who has
theoretically,
sudden
yes, but
anyone who has sudden onset hypertension can have hyperaldo. So hyperaldo can be present in young, middle age, or old. The main question is this new onset resistant hypertension, or this is just a progression and worsening of their essential hypertension? So the case that I'm presenting was built and for a worsening hypertension. So that's kind of how that is. Okay. So hopefully, again, lots of controversy in this, but predominantly my main take home was that in someone who is not a candidate for surgery, then you can proceed as treatment for resistant hypertension with spironolactone. If let's say this was a 30-year-old person with resistant hypertension and you thought hyperaldo, then absolutely you wouldn't wait to start spironolactone. To take the telmisartan off, you would do the PRA aldosterone, you would do the adrenal vein sampling, you would do the surgery, kind of go on that pathway. Or you would do the Doppler as well if the PRA aldo was normal and you thought that this was renal artery stenosis, fibromuscular dysplasia, in which case you would intervene on that. So again, a 30-year-old with intervention possible, or even an old person, 60s with intervention possible, is a different story. But the reason I kind of built it up was someone who wasn't going to go for surgery. Okay. So now we'll go to case 18. So this is someone with sudden onset hyponatremia with symptoms, and the treatment for symptomatic hyponatremia is a 3% bolus or a drip. And so the answer is 18B, which is 3% 100 ml IV stat, and can be given by a peripheral vein as well. The things to do are to monitor closely of the serum sodium and then stop or reassess. And then depending on how the rate of infection is, and how the symptoms are, you can decide further treatment beyond that. But at the time they have symptoms, they have a low sodium, you want to give 3%. And again, another caveat is tolvaptan is not for symptomatic hyponatremia. So please don't give tolvaptan for symptomatic hyponatremia. So that's case 18. Case 19 is a hyperkalemia dialysis patient. And again, the question is which of these is the most critical in saving the person's life? And the answer is B, which is calcium gluconate, which will stabilize the membrane. So treatment goal number 1 is stabilizing the membrane. So you give calcium gluconate. The action starts within minutes, lasts 30 to 60 minutes. And again, you repeat the dose every 5 minutes. ECG normalizes. People who heard me talk will know this ECG as well. And so this is original ECG that was then. This is K of 8.1. You give more calcium and now you'll start seeing the P waves come back and the QRS is narrowing. And this was 18 minutes into, we gave more calcium, and then this is now 27, 30 minutes, and the ECG is normalized. And then you start dialysis later. In terms of the other treatment options, so if you look at insulin and glucose, usual dose is 10 units of insulin with 50 ml of 50%, and the onset is 10 to 20 minutes. Impact is 0.5 to 1.2 MEQs. Duration is 4 to 6 hours, and you have to watch out for hypoglycemia. And this is a good drug, but it will not save the person. It will the killer in hyperkalemia is the cardiac and heart arrhythmias, and so the calcium will stabilize. Insulin and glucose by time. Albuterol, you have to make sure to give 10 to 20 mgs. The usual dose is 2.5 mg. And the impact and onset is 90 minutes, lasts 4 to 6 hours. Impact is 1.2 to 1.5 MEQs per liter. It has additive effect to insulin. So that is something that is useful if you do together. However, you have to watch out for tremor and tachycardia. Bicarb, you can give a bolus, so you can give it isotonic bicarb infusions. Onset is 30 minutes, impact is 0.5 to 1 MEQs, and duration is 4 to 6 hours. However, in dialysis patients, it's been shown to be very useless. And unless you're acidotic, bicarb may not have much impact. Then goal 3 is to get rid of potassium by dialysis, diuretics, and raisins. That's hyperkalemia. And then the last case is someone with PD, and kind of how do you dose PD for someone who's especially anuric? And so that's the question. And the guide is 3 things. One, you have to look at the weight, 50 kgs. Second is you have to look at what kind of transporter the person is. So this is someone who's a poor or slow transporter, a low average transporter with a DP creatinine of 0.5 at 4 hours and a DD0 0.55. And so what you want is someone with this kind of low to low average transporter to have as much time with fluid in their belly as possible. And so you want 24-hour coverage. The other is you want to assess your PD dosing. Your target KT by V, no very good answers, but let's say we'll take a KT by V of 1.7 for the week. So the weight is 50 kg. So water distribution 0.6, 30 liters. So now you take 30 liters into 1.7. So 1.7 into 30 is 51 liters. So that's the clearance that you want in a week. So 51 liters per week, divided by 7 so that you get daily. So for daily, you need 7.2 liters of clearance per day. And what we've already shown with the PET test is a 4-hour dwell gets you 50% clearance because your urea or D by P is 50, 0.5. So all your 4-hour dwells, you have to count as 50% clearance. So if you put in 2 liters and you get 2 liters out, and we are not counting ultrafiltration for now, so 4 dwells of 2 liters means 8 liters. And 8 liters at 50% is 4 liters of clearance. And we'll take 2 liters of icodextrin over 8 hours. Over 8 hours, we would expect a low to low average to get close to 100% urea equilibration or creatinine equilibration. And so we'll take that the 2 liter icodextrin we'll take 1 liter ultrafiltration. So that's 3 liters. And at 100%, that's 3 liter clearance. So when you do 4 dwells of 2 liters each, and then 1 icodextrin for 8 hours as well. So that's a 24-hour coverage, and that gets you 7 liters. All the other options that are there, so whether it's the 2 liter 2 dwells, or so that will be 4 liters plus 2 liters of icodextrins, that will get you about 4 liters will be about slightly more than a half because it's 6-hour dwells. And then the icodextrin would give you 2.5 liters or 3 liters as well, but that will get you around 6 liters of clearance. The cycler, because it will be changing over 2 hours, efficiency will be much lower. Even though you have 10 liters, it will probably be at around 30 to 40% clearance. That will give you like 3 to 4 liters of clearance. And again, 1 dwell of 4 hours or 2 liters will give you 1 liter of clearance over 4 hours because it's 50%. And the cycler over 8 hours will also be around 30 to 40%. A low average transporter, as we are describing here. So that is why option B is what would provide you the appropriate. So the question is, for icodextrin to be effective, should it stay in the abdomen for more than 10 hours? So again, you want longer duration because it doesn't have sugar that is getting reabsorbed on the other side. Anything above 8, 10, 12 hours is a good option. It will depend on what other dwells and how the lifestyle of that person is. So you can kind of time it that way. If you give it longer and you do a 12-hour for this patient, the problem is then you have only 3 other exchanges. And so that will give you 6 liters plus 2 liters, so 8 liters. And so that will not be enough for someone who is anuric. So if you need a higher volume to go into someone, then you'll need to shorten your icodextrin time, which is what we needed to do for this patient. But you can do a 12-hour icodextrin as well if someone is not, if let's say someone had some residual renal function. You could do 2 or 3 dwells during the day and a 12-hour icodextrin for a longer stay. So someone missed the dialysis patient clearance. So I'll go back to that question as well. And so the answer is predominantly based on time is the right answer. So if you increase time from 3 hours to 4 hours, that's a 1/3 increase, 1 hour increase over a baseline of 3. So that's 33% increase compared to changing the dialyzer, which gives you an increase of 10 over a previous of 300. That's 3%. Increasing blood flow of 300 ml per minute. Urea clearance for 300 ml per minute is 250. Increase the blood flow to 400, you get 300 ml per minute. That's an increase of 16%, and increasing dialysate gives you 10%. Now I'll pass over to Sagar, and we'll have his questions to go forth.
Sure thing. Thank you, Ajay. I'm going to try again. We have Varsha in the back as a backup in case there's a hiccup again. So I'll start off by sharing off my screen. Is the screen visible for question number 1?
I think it's loading up. Yes, now it is.
It's there, sir.
Alrighty, so we'll start off. So question 1, we have a 58-year-old guy who's hospitalized following loss of consciousness and seizures while working in the garden. He had been well, but reported muscle cramps for a few weeks now. His past medical history includes esophagitis, pneumothorax, hypertension, hypercholesterolemia, and a hip fracture, and a similar episode of seizures 1 year back. His current medications includes omeprazole for 8 years because of epigastric pain, and captopril and simvastatin each for 6 years. There was no history of alcohol abuse. The physical exam is essentially normal other than a positive Trousseau sign. Lab studies was significant for HB 12.4, creatinine of 1.1, sodium 142, a potassium of 2.7, bicarb was 24. The calcium is low at 6.7, phosphorus is 3.6, magnesium is low at 0.72 milligrams per deciliter, and then albumin is normal at 3.9. The 24-hour urine study revealed a creatinine of 1200 milligrams, sodium 123 milliequivalents, calcium 54 milligram, and magnesium 10 milligram. So coming to the question, what is the likely cause of hypocalcemia and hypomagnesemia in this patient? One is paraselin-1 gene mutation, familial hypomagnesemia with hypercalciuria and nephrocalcinosis. 2 is hypoparathyroidism. 3 is omeprazole. 4 is Gitelman syndrome. Again, what is the likely cause of hypocalcemia and hypomagnesemia in this patient? Paraselin-1 gene mutation, hypoparathyroidism, omeprazole, or Gitelman syndrome. We'll move on to the next question. Question 2. A 49-year-old female patient has been given a clinical diagnosis of multiple myeloma nephropathy after she presented with progressive renal failure, lytic bone lesions, and thrombocytopenia. Her serum protein electrophoresis showed high levels of IgG kappa. Which of the following findings may be present in the kidney biopsy? So we're talking about a 49-year-old female patient with a diagnosis of multiple myeloma nephropathy. What do you expect to see in the histology in the kidney biopsy? A, fractured tubular casts. B, Congo red positive glomerular and tubular deposits. C, acute tubular injury or necrosis. D, plasma cell infiltrates. E, you can see all of the above. So again, the question is asking you, a 49-year-old female patient with multiple myeloma nephropathy, what do you expect to see on the histology in the kidney biopsy? Fractured tubular casts, Congo red positive deposits in the glomerulus and tubules, ATN, plasma cell infiltrates, or essentially all of the above is possible. Moving on, question number 3. In nephrotic patients with a diagnosis of FSGS in nephrotic patients with a diagnosis of FSGS, focal segmental glomerulosclerosis, which lesion is associated with the highest response rate to treatments with steroids and actually has the best prognosis? A, FSGS NOS, not otherwise specified lesion. B, perihilar lesion. C, collapsing lesion. D, cellular lesion. E, tip lesion. So basically in the subtypes, the histological classification of FSGS, which subtype has the best prognosis and the highest response rate to the treatment with corticosteroids? NOS, perihilar, collapsing, cellular, or tip lesion. These are shorter questions, more like, whether you know it, more fact-based. A bit longer question. The question 4, a 66-year-old Caucasian male has severe degenerative arthritis of the hip and lumbar spine. He has tried Tylenol, which is the American version of acetaminophen or paracetamol, without successful alleviation of his pain. The pain is constant and disabling him. His rheumatologist now places him on a non-steroidal anti-inflammatory drug on a daily basis. The pain is controlled and the patient is much more mobile. He feels a lot better. After taking the NSAIDs daily for the last 3 months, new symptoms have developed that include lower extremity swelling and worsening blood pressure. Lab studies reveal the following: sodium of 140, potassium 5.6. The urinalysis shows a protein 4+, chloride RBC 123. The urinalysis also shows 10 to 15 WBCs. The creatinine is 2.0. On exam, he has a blood pressure of 160 by 100, pulse 80 per minute, 3+, pitting edema of the lower extremity to the thighs, edema of the hands, heart and lung sounds are clear, abdomen is normal. So talking about a 66-year-old guy, recently started on NSAIDs daily for the last 3 months with 3+ pitting edema, hypertension, and worsening blood pressure. What is the most likely diagnosis? Interstitial nephritis and FSGS, interstitial nephritis and minimal change disease, interstitial nephritis alone, interstitial nephritis and mesangial proliferative glomerulonephritis, interstitial nephritis and membranoproliferative GN, MPGN. So 66-year-old guy recently started on NSAIDs for the last 3 months. What do you think you're going to expect if you biopsy him? Interstitial nephritis with FSGS, MCD, interstitial nephritis alone with mesangial proliferative GN, or membranoproliferative GN? All right, moving on. Next question, question number 5. In patients with evidence of stage 4 CKD with associated proteinuria, increased free serum light chains, normal free light chain ratio, absence of bony destruction on evaluation, and equivocal bone marrow biopsy result, which of the following statements is correct? So the question again, a patient with stage 4 CKD, an estimated GFR of 26, who has associated proteinuria, increased free serum light chain, normal free light chain ratio, absence of bony destruction on evaluation, and equivocal bone marrow biopsy result. Which of the following statements is correct? A, the patient should be observed in bone marrow biopsy repeated in 3 months. B, elevation of free serum light chains is most likely the result of decreased GFR in this patient. C, the patient should undergo a kidney biopsy. D, the patient should undergo a PET CT scan to evaluate for the possibility of malignancy. So again, the question is asking you, there's a patient with stage 4 chronic kidney disease, eGFR 26, who has proteinuria, increased free serum light chains, normal free light chain ratio, absence of bony destruction, and an equivocal bone marrow biopsy result. What do you think out of these 4 is correct? All right, moving on. Question 6. A 20-year-old man is referred for evaluation of hypertension. He believes that his hypertension was first diagnosed at age 16, but he was never told what it might be from. His father died at age 42 with a stroke, and he has a brother aged 23 with hypertension. On exam, he is normal appearing with a BP of 170 over 100, and his fundoscopic examination reveals mild arterial narrowing. There are no abdominal bruits. Serum sodium is 144, potassium is 3.1, bicarb is 29, creatinine is 1.1, urine potassium is 89, plasma aldosterone level is 6 with a renin activity of 0.5. Which of the following would be the most likely cause of his hypertension and associated lab findings? A, Gordon syndrome, B, Little syndrome, C, Bartter syndrome, D, Gitelman syndrome, E, primary hyperaldosteronism. All right, that was a bit of a long question, so we waited a little longer. I would move on. I hope most people have put down some answer to the question. If you want to come back to this question or wait a little longer, just let me know. We can go back to that slide. Alrighty, question number 7. A medical student asks for your help on an acid-base disturbance question that he recently encountered during the medicine rotation. The following labs are presented to you and the student does not remember the history of the patient. Sodium of 140, potassium 2.0, chloride 115, bicarbonate 15, pH 7.32, PCO2 of 30, PO2 of 84 mmHg. So again, the medical student does not remember the history of the patient. If you were given only these values and had to make a diagnosis on the acid-base disturbance, which of the following description of the acid-base disturbances in case is true? It's a high anion gap metabolic acidosis, respiratory alkalosis and metabolic alkalosis, non-anion gap metabolic acidosis, both high anion gap and non-anion gap, as in both A and C, or E, all of the above. Again, looking at the values here, sodium 140, potassium 2.0, bicarb 15, chloride 115, pH 7.32, PCO2 30. Which of the following is the correct answer for describing the acid-base disturbance in this equation? Alrighty, I hope all of us have been able to figure it out. We're going to move on to the next question, question 8. A patient undergoes post-operative ultrasound of his AV fistula 6 weeks after its creation. The ultrasound reveals a diameter of 3.3 mm and an access flow of 350 ml per minute, suggesting that the fistula will not be successful. The patient has an EGFR of 18 ml per minute and has not yet started dialysis. The best course of action is refer the patient back to the surgeon for a new vascular access, repeat the ultrasound in another 1 to 2 months to assess fistula maturation. Sorry. C, ask the radiologist whether the fistula reveals correctable anatomic problems. D, encourage the patient to perform fist clenching more consciously. So again, this is an AV fistula made for a patient with CKD stage 4, EGFR of 18. This is 6 weeks post-operative. The ultrasound reveals a diameter of 3.3 mm and access flow of 350. What do you do at this stage? Refer the patient back for a new fistula, repeat the ultrasound in another 1 to 2 months, ask the radiologist if something is fixable, encourage the patient to perform the fist exercises more religiously and consistently. Alrighty, moving on. Question 9. Which of the following statements about cerebral aneurysms in ADPKD is true? Cerebral aneurysms affect 20% of all patients with ADPKD. Cerebral aneurysms cluster within families. Screening for cerebral aneurysms should be carried out in all patients with ADPKD. Cerebral aneurysms more than 5 mm in size are associated with a 50% chance of rupture. New cerebral aneurysms arise frequently and patients should be screened every year for their occurrence. Again, which of the above 5 is true about cerebral aneurysms in ADPKD? Please go through the options again. Option A, they affect 20% of total patients with ADPKD. They cluster within families. C is screening should be carried out in all patients with ADPKD. D is cerebral aneurysms more than 5 mm in size are associated with a 50% chance of rupture. And E is new cerebral aneurysms arise frequently and patients should be screened every year for their occurrence. Alrighty, moving on to the last question, question number 10. A 77-year-old man with type 2 diabetes, gout, hypertension, dyslipidemia, and stage 3B, the EGFR is around 40, presents with chest pain and ECG changes consistent with MI. He undergoes a cardiac catheterization and is pre-treated with IV fluids to reduce chances of CIN. The patient develops transient hypotension during the procedure with BP dropping to 72/48. He received a total of 100 ml of non-iodinated isoosmolar contrast during the procedure. Over the next few days following the procedure, the patient develops severe hypertension and GI bleeding. The serum creatinine increased to 6.5 and the patient requires hemodialysis for uremia and hyperkalemia. He remained dialysis dependent for 3 weeks before recovering to a new baseline serum creatinine of 4.9. So what is the most likely cause of AKI in this patient? A, contrast-induced nephrotoxicity, B, cardiorenal syndrome, C, acute tubular necrosis, D, cholesterol embolization, or E, acute interstitial nephritis. So again, a 77-year-old male with type 2 diabetes, hypertension, dyslipidemia, EGFR of 40, undergoing cardiac angiography, and he had hypotension during the procedure, the BP down to 72/48. He received 100 ml of non-iodinated isoosmolar contrast. And then over the next few days, he developed severe hypertension and GI bleeding. The creatinine increasing to 6.5 and the patient needing dialysis. Being dialysis dependent for 3 weeks and now then coming down to a new baseline creatinine of 4.9. What do you think was the cause of AKI in this patient? Alrighty, so I asked in the chat if everybody had enough time to catch all the questions and put down some answer. I think the response this time is enough. So let's keep rolling and go on to the answer key. So the question, you could see a symptomatic patient who had hypocalcemia, hypomagnesemia, and a positive Trousseau sign. The question was, what is the likely cause of it? The correct answer to that question was omeprazole, or the PPI causing the above. So hypocalcemia and low parathyroid hormone is a known complication of hypomagnesemia. The low urinary magnesium excretion indicates that the renal handling of magnesium was intact, and the cause of the hypomagnesemia is impaired intestinal absorption of magnesium. Of the causes listed above, only omeprazole is associated with impairment in magnesium absorption. The familial FHHNC and Gittleman's are cause of urinary magnesium wasting. The 24-hour urinary mag was going to be high there. Hypoparathyroidism and hypocalcemia, they are not usually associated with hypomagnesemia. So the best plausible answer was the PPIs causing hypomagnesemia. Anybody there? What is the mechanism? How PPIs do it? Who can type out the answer in chats first? How do PPIs cause wasting of magnesium through the gut? Mitesh says inhibition of. I like that is a smart answer. Inhibition of magnesium channel. Yes, the answer is TRPM6. So it inhibits the trans receptor membrane protein 6 in the gut, which leads to magnesium wasting. And this is very important to know in clinical practice. Question 2. A 49-year-old female patient has been given a clinical diagnosis of multiple myeloma. What do you expect to see on the histology findings if you have to do a kidney biopsy? The correct answer is E. Although whenever we talk about multiple myeloma, we keep talking about cast nephropathy as the predominant pathophysiological mechanism by which you develop AKI. So cast nephropathy is the most common finding in myeloma with renal failure, but actually the other options, all those entities can occur either alone or in combination. Amyloidosis, light and heavy chain deposition disease, fibrillary GN Fanconi, renal tubular acidosis from light chain proximal tubulopathy, membranoproliferative glomerulonephritis, infiltration with plasma cells, ATN, and uric acid nephropathy. So all these findings can actually coexist on the histology. Cast nephropathy, while being the most predominant phenomenon, that's not the only thing. Question 3 was a nephrotic patient with FSGS, which has the best response rate. The correct answer is in nephrotic patients with FSGS, the tip lesion has the best response rate to corticosteroids and the best prognosis, whereas patients with a collapsing lesion are less likely to respond to the treatment and have the poorest prognosis. Any questions so far? Please feel free to comment in the chat section. Question 4. So this was a 66-year-old guy who was started on regular NSAIDs for the last 3 months, who developed worsening blood pressure and lower extremity edema. The correct answer to the question being posted was, what do you see in the histology? The correct answer is interstitial nephritis and minimal change disease. So this patient had evidence of AKI with nephrotic syndrome. He was taking NSAIDs, and NSAIDs, all of us, I think by this stage, know that it can cause minimal change disease and AIN. Most patients with this syndrome due to NSAIDs do not develop the triad of fever, rash, and eosinophilia. Actually, in your clinical practice, I don't know. maybe Dr. Ajay can say, like, how many patients actually have the classical triad of fever, rash, and eosinophilia. This is diagnosis of usually, clinical suspicion. Most patients, there would be no reason to suspect de novo FSGS in this guy, when you have a well laid out history to NSAIDs, and NSAIDs per se have not been associated with FSGS. Myeloma kidney is a distinct syndrome, with the predominant kappa light chain injury. And the patient would have AKI with non-nephrotic range proteinuria. NSAIDs have also been associated with membranous and interstitial nephritis, but MPGN and mesangial proliferation has not been described that often. The hyperkalemia is likely due to RAS inhibition from NSAID use. This is also something you will definitely come across in clinical practice, being seen in a lot of patients. The NSAID-induced hyperkalemia part also. So the correct answer is, apart from the interstitial nephritis, the patient can have minimal change disease, which has caused the nephrotic range proteinuria. Any questions so far? Well, that again, takes me to a small clinical point. Whenever you are evaluating a patient with nephrotic syndrome, while you are, taking your history, do take a detailed drug history, and I'm sure you're going to see some NSAID-induced minimal change disease like pattern in your clinical practice. Sometimes, in some cases, you can do watchful waiting if that patient is not the right candidate for biopsy. But again, always take a detailed history about the drug intake. This question was question number 5, stage 4 CKD. Patient has proteinuria, increased free light chains, but a normal free light chain ratio. That was the key. There's no bony lesions and the bone marrow is equivocal. So which of these following statements is correct? The patient should be observed and bone marrow biopsy repeated. Elevation of free light chains is most likely the result of decreased GFR. You want to do a kidney biopsy here, or you want to do a PET scan to evaluate the possibility of malignancy? So the correct answer is going to be B. Elevation of free serum light chains is most likely the result of decreased GFR. Even light chains, if you look at the pathophysiology of multiple myeloma, what is going on? The light chains are filtered through the tubules, but like in myeloma, they are being produced in tremendous amount, much more amount the tubule can actually handle. That's why when they get filtered, they keep going, and when they get into the distal tubule, they start getting blocked because their excretion capacity has already been saturated. The chains are secreted out, but they're being produced in so much amount that now you can't throw them out enough. So they all start clogging the tubule and getting deposited there. And when you actually prepare that slide, it's called, the cast nephropathy, the broken casts. So that is what is happening in myeloma. So if you come to this question, basically it points out to the fact that patient with CKD stage 4 has a decreased renal clearance, and hence the absolute value of light chains, most commonly which are kappa and lambda, the kappa and lambda light chains can be elevated in the serum. But if their ratio is normal and you're not seeing any signs of end organ destruction, there's no bony destruction, the bone marrow is equivocal. So in such a case, you can be rest assured that the high light chains are because of the decreased GFR. So like I said, light chains are filtered at the glomerulus, and the reduced GFR will increase both kappa and lambda absolute value. Increased kappa lambda or decreased kappa lambda ratio would be supportive on monoclonality and potential paraproteinemia. Finding elevated monoclonal light chains and evidence of kidney disease would then be an indication for the biopsy. At this point, there's no reason to do a PET scan and evaluate the possibility of malignancy. So again, the learning point here was you got to know. There's a question out here. The question was, why not biopsy? I believe Dr. Bhanu Mishra, you wanted to ask, why not a kidney biopsy? So Well, my answer to that question would be this patient, you're right in the sense this is CKD4 with proteinuria. So of course you have to do a detailed history and physical examination to see what was the reason. Is the patient diabetic, hypertensive, or what else was going on? And again, but the question was more of an academic question which wanted to emphasize that you're going to order free light chains or a protein electrophoresis a lot of times in such patients, but a slight elevation in the absolute levels, like, you could see a bit of elevation, 80, 100, 130s in your clinical practice. You don't want to jump onto a biopsy right away. You've already done a bone marrow, so you've ruled out like myeloma or a Waldenstrom's or some other, paraproteinemia. And the bone marrow is easier than a kidney biopsy. This is the last question: why was the bone marrow done? The bone marrow is, I would call it, a less invasive test than the kidney biopsy. So again, the teaching point in this question was why, like, you do not want to jump to a kidney biopsy if you see elevated light chains. So that was the most important teaching point. You want to keep an eye on this patient. You want to keep getting the light chain levels. You can repeat those in a couple of months. If you see one of the light chains elevated more or the ratio getting skewed, yes, you may want to consider then. There's another fact. B is a fact, C is subjective. From like Dr. Arun said here, again, yes, if you've established this is CKD already, and at the EGFR of 26, you may or may not be able to offer a therapeutic change with the biopsy results. But again, coming back to the fact that the learning point here in this question was, whenever you see elevated free light chain results, always put it into clinical context. The absolute levels of light chains are going to get higher with CKD and decreasing renal clearance. The ratio is going to stay usually in the normal limit. You want to do your other studies like protein electrophoresis, immunofixation. The bone marrow is a lesser invasive, and I would call it a safer procedure than the kidney biopsy here. So again, that was the key teaching point here. Kidney biopsies, you're always going to have a subjective look. A lot of people may want to biopsy one kind of patient. Others may not think it's going to make a therapeutic difference. Sometimes there's not a right or wrong answer. But again, this question thrown in here was more for academic reasons, saying, what to do when you see an elevated light chain level. The the take-home message is you have to put it in clinical context. Look at all your results together before you jump onto a kidney biopsy, and also keeping in mind that the light chain excretion is going to decrease with the fall in GFR. Question 6, we had this 28-year-old guy with hypertension, strong family history, blood pressure of 170 over 100. The potassium was low at 3.1. The bicarb was 29. The urine potassium was 89. The plasma aldosterone 6, renin activity 0.5. Asking what was the cause of kidney disease here. Well, so the differential diagnosis for a patient with hypertension and renal potassium wasting, that is clearly evident in this case, was primary aldosteronism, malignant hypertension, syndromes of mineralocorticoid access, Cushing's, Liddle's, and apparent mineralocorticoid access, which can happen with licorice administration, not too commonly seen here. So the Gordon syndrome or the pseudo-hypoaldosterone type 2, that is going to give you hyperkalemia and metabolic acidosis. This patient has hypokalemia, and so this is not a fit here. Barter's and Gittleman's, they are notable for the absence of hypertension. This patient is being evaluated for new onset hypertension, not new onset, sorry, long-standing hypertension. His BP was 170 over 100. The finding of a plasma aldosterone level of 6, that essentially excludes primary aldosteronism. So Liddle's is most likely the etiology for this case. Again, sometimes you have to go exclusion wise with all the options and see what's going on. Any other questions so far till question 6? Are we noting down all the answers? The answer to this one was Liddle syndrome. All right, then in this case, we'll move on. Question 7, this is a simple acid-base equation. So this might be an easy one for a lot of you there. I'm sure, you know, most people know this. But the point I wanted to make on here is, we do less acid-base in our daily lives, on our daily rounds than we should. Like if some med student or a DNB medicine is rotating with me on my rotation, I usually do the acid-base chapter right in the beginning, in the first week of the rotation. That way, whenever I go on rounds, you know, and we see an ABG in MICU, CCU, wherever, quick, I can, you know, kind of quickly quiz them, you know, what's going on here. So again, this might be quite easy for all you nephrology folks out there, but I think for medical students, internal medicine residents, we should have this on our tips and then re-emphasize it and teach it to our trainees. So this patient had a PHF less than 7.4. So it's of course acidosis. There was no anion gap. The respiratory compensation was appropriate. So the correct answer was C, non-anion gap metabolic acidosis. So a non-anion gap metabolic acidosis in clinical practice, it's most commonly with RTA or GI loss of bicarbonate. Medication such as carbonic anhydrase inhibitor or the drug Topamax, that can lead to such findings. So you should, again, you know, for your clinical practice, remember what is an anion gap metabolic acidosis or non-anion gap metabolic acidosis. What are the most common causes for an anion gap metabolic acidosis? I'm sure all of you have read the acronym MUD piles, you know. Another one I used to use to kind of quickly think was CULT, which is ketones, uremia, toxins is a broad term, and lactate. So in like on clinical rounds, I found like most cases are going to fit in one of these for anion gap metabolic acidosis: CULT, ketones, uremia, toxins, or lactate. Toxins again is a broad heading. The non-nephrology folks are not going to see a lot of toxins, but we can come across many cases, you know, salicylates. Recently, it was a sad, unfortunate case, you know, a 16-year-old boy ordered some, you know, what do you call, antifreeze, ethylene glycol from Amazon and tried to consume it during the COVID lockdown because of frustration. So we saw that case. But again, this is one of those things that, you know, you should remember and have it on your tips so that you can quickly scroll through these numbers on ABG and your KFTs and come to the answers. Any questions out there? No. In that case, we proceed. The question 8. This was about an AV fistula 6 weeks post creation, and you know this is clearly suboptimal. Anybody knows the rule of 666 for AV fistulas? Or if you want to type it out here. So well, the other 6 is 600 ml per minute. So not 6 weeks, but 6 mm diameter, 6 centimeter length, and 600 ml per minute flow. That is the rule of 666 for AV fistulas. 350 ml flow right in the beginning, that's never going to be optimal. I think Dr. Ajay Kher's question, you very rightly learned about, you know, how you can increase your KT by V, have your urea, the clearance is adequate. So the AV fistula is a big part of it, you know. Remember, just to point out, you know, nothing against anyone, but in India, often I've seen a lot of peripheral centers and even major centers, you know, the technicians like to run the patient on 250, 500 or, you know, 200, 300 flows all the time. It causes less alarms, but again, that can drop your clearances significantly. So you have to work on your accesses. If your access is good, you can clearly, you know, dialyze them up to 400 ml per minute. if if the patients who were taller and broader, African American patients with huge fistulas, we even went up to 500 ml per minute in the US. I would be myself a little scared in the small Indian patient with the crumbing fistula, but if your fistula flow is good, 400, 450, you can easily get there. Like Dr. Ker mentioned, above 400, your clearances are going to plateau. So there may not be a lot of good part beyond that. Also remember your catheters. Most catheters, if you used a good size catheter, you can easily get a flow of 400. So at least, your permacath or your temporary line patients, you should run them on good flows to give them good clearance. Whenever you round as nephrologist in the unit, make sure you look at all these blood flow parts, the access, to maximize the benefit of the treatment. Either ways, a lot of patients are going to see you maybe once a week or twice a week dialysis. If you can optimize that treatment to the maximum amount of possible, so that's going to be good. So one other point in one of the options here is encourage the patients to perform fist clenching exercises more consciously. Well, remember, as a difference, I don't know, I found out that often rounding in the dialysis unit when the fistula is not ready, we kind of lay a lot of emphasis on fist clenching exercises or isometric exercises. And often when the fistulas don't mature, we sometimes put it on the patient that, oh, you didn't exercise well. But if you actually go home today, open PubMed, do a thorough literature search on this topic, you're not going to see many studies that strongly support fist clenching or isometric exercises. The evidence to support this is at best weak. We should obviously tell the patient that they have to do this, but never you can say that, okay, this is the only thing or this is the rate limiting step that's going to make your fistula, grow bigger or mature well. So this patient at 6 weeks, when you've done an ultrasound, you saw, the flows are inadequate. What are you going to do? You don't have to jump into a new vascular access right away. The option A, there's no point waiting beyond 1 to 2 months to assess fistula maturation. The correct answer would be to ask the radiologist whether the fistula reveals a correctable anatomic problem. So if you can have that and fix that, you can salvage this. Always remember there are counted sites. You can make a fistula or put a graft in or throw a catheter in. So access is the backbone of dialysis patients continuing to do well for a longer time. So again, it is very unlikely that the fistula will mature without beyond 6 weeks. Many mature fistulas are found to have an underlying anatomic problem. Correction of this problem may promote fistula maturation. There might be a juxtaanastomostic stenosis that can be treated by angioplasty or surgical revision, or large accessory veins that can be ligated. Appropriate interventions frequently convert an immature fistula to the one that is suitable for dialysis. Again, lastly, like I said, there's no published evidence that fist clenching promotes fistula maturation in a very strong manner. Any questions so far? Feel free to type it out in the chats. Question 9, autosomal dominant polycystic kidney disease and cerebral aneurysms. Well, this is more kind of a fact-based question. Either you know it or don't know it. The correct answer is explanation the B, the cerebral aneurysms cluster within families. So patients with ADPKD, all of us know have an increased incidence of cerebral aneurysm. Just this week, I had a patient, he bled his basically cerebral aneurysm, that bursted. His brother had a kidney transplant at our center. He had ESRD from PKD. Anyways, so with the family history of aneurysms, the incidence is approximately 20%, not 20% of total patients with ADPKD. In all patients with PKD, the incidence is closer to 2 to 5%. Therefore, screening for cerebral aneurysms is not recommended for all patients. So whenever you are evaluating a new patient, you find a new PKD, make sure you take a good history. That is again important for treatment specific drugs also. What is the pattern, family history? Has anybody had brain bleed or a sudden death before? If the aneurysms are detected more than 5 mm in size but less than 10 mm, they can be followed since the risk of rupture is low. The ones with greater than 10 mm, the chance of rupture increases. Aneurysms do arise in previously screened patients, and most experts believe that patients with known aneurysm should be rescreened every 2 to 3 years and not annually, to monitor for occurrence and to monitor the growth already present. So you don't have to screen them every year. And again, the chances of rupture increase over 10 mm, and it is 20% in families where the cases are clustered, not of total patients. The total incidence of aneurysms in PKD is only 2 to 5%. Last question, question number 10. So basically a 77-year-old guy with all the risk factors for getting CAD, diabetes, hypertension, hyperlipidemia, had an angiography, plasty, he developed hypertension and then GI bleeding, and the serum creatinine rose to 6.5. So the reason I put this question on here, this is something that you're going to see every day on your nephrology job. You know, every single day somebody like CCU is always going to call you for such cases. The correct answer to this question is cholesterol embolization. So this patient had AKI, you know, he went from, they didn't put the initial creatinine down here, but he went from EGFR of 40 down to 6.5, you know, probably GFR of less than 10, 15. So he did have AKI with severe hypertension and GI bleeding. So this is most likely cholesterol embolization to the kidneys and GI tract. If you ask me, I think it, like along with CIN, which is, you know, of course, the first thing that is in everybody's mind, this is a very, very important complication. This is not uncommon. A couple of months back, we actually biopsied a severe AKI exactly like this, but he did not have GI bleeding. But, you know, presuming it to be CIN, the cardiologist kind of left him out. He came in a month and a half after his angioplasty. And then when we biopsied him, we actually saw cholesterol embolization. So this course was not consistent with contrast-induced AKI. You know, we know the creatinine can start going up from day 2, usually it comes down to its baseline value from day 5 to day 7, but there is a chance that they can prolong to severe AKI. But this guy had prolonged severe AKI and ended up with worsening CKD after the procedure. So again, cholesterol embolization is a very important phenomenon that all of us have to keep in mind to explain, you know, those non-CIN like cases or where the renal failures has persisted for a prolonged time. The hypotension in the cath lab was transient, you know, unlikely cause severe ATN. AIN is unlikely, you know, we've not been given a history of new drug exposure or other than contrast. There's no new infection history here. And, you know, this clearly doesn't look like cardiorenal syndrome on here. So again, cholesterol embolization is very important, something that you always have to keep in mind on your clinical rounds as a nephrologist. So with that, I bring this to a close. So that's a great question. How do you exclude ATN in this patient? ATN is always going to be possible, you know. Someone with transient hypotension, even for a few minutes, can develop ATN. There is really no correlation. You know, on the other hand, you see a kidney transplant, the kidney is cut off, tied and put on ice, you know, for such a long time, and you may not get ATN. So ATN, there's no set pattern. But in this case, Mitesh, I think one thing they specifically want you to look at is he did develop, you know, GI bleeding, and he developed severe hypertension. I would not expect to see that with ATN. So I think they were trying to draw your attention to this possible complication. The other question is, recovery is expected in how many percentage of patients in atherosclerotic disease who has reached dialysis? Honestly, I don't know the exact statistics on this, but I would guess something around 60-70% are gonna recover. Again, their initial CKD, how extensive, you know, was the atheroembolization? How did you, you know, treat that patient during dialysis? What were their baseline blood pressures? If they have recurrent hypotension during dialysis treatments, that's going to keep causing additional insults. I think a lot of factors are going to clinically determine what is going to, you know, help with the recovery of renal function in such a patient. But yeah, good question. I would have to look it up. But I wish I could show you the images of the actual patient. We biopsied post angioplasty, and how beautifully he had cholesterol emboli lighting up on there. So again, the teaching point here was keep that complication in mind always. Okay, coming to a close. Dr. Ker, are you there?
Yeah, I'm here.
Anything else you would like to add on, or?
No, I just would like to say best of luck to everyone, and welcome to our peer group of being consultants in nephrology soon. So I hope to see you guys around in Delhi NCR in our conferences and our other sessions. So and welcome to the group.
Yep, welcome everyone. Good luck for your exams. Really, COVID has been teaching us a lot, other than the clinical thing, the change in exam patterns, and these questions are good sometimes. You will apply all of this in your daily rounding and your daily practice. So. All right, can we bring the session to a close, sir? Dr. Ker?
Yes, sir. Thank you so much. Thank you, Dr. K. Thank you, Dr. Sagar. I think this would have helped the students much more what they needed at this hour. Thank you again.
All right. Thank you.